This is an ABC podcast.
Last night, the Grattan Institute released a report called Coming Out of COVID-19 Lockdown, the next steps for Australian healthcare. It includes modelling on the effects of lifting the various restrictions, and as I said earlier, it's timely given the troubling increases in cases in Victoria. The lead author is Professor Stephen Duckett, who runs the Grattan's health programme. Welcome back to the Health Report, Stephen.
Thanks, Norman.
So is what we're seeing in Victoria the result of lifting restrictions too early?
I think probably it is. I think there's a combination of bad luck in what's happened. There's a combination of the community being complacent. There's a combination of the community not taking notice of the lockdown rules. And there's, we lifted restrictions when the virus was still circulating in the community, and that's always a risk.
But Victoria had some of the strictest restrictions in the country, and we're late to reduce restrictions compared to other states.
But even when we lifted those restrictions, we weren't down to zero for a fortnight or whatever it is, and so there was the virus circulating in the community there, and so it was always a risk that when we lifted the restrictions, that there'll be these outbreaks, and there have been.
Now, you wrote this report fearing that we're not learning from the experience. What evidence have you got for that? Well, I suppose that Victoria's one, possibly.
Yeah, so, some of the states have learned from the experience, and what's interesting is the debate that's going on right today about should Western Australia and Queensland open their borders. And you've still got the Prime Minister saying Queensland should open its borders, the Premier of New South Wales, Queensland should open its borders. And so if you're in Queensland, you're under this pressure and you say, well, is this really the right thing for us to do in Queensland when it brings with us the risk that we'll have more infections in Queensland, which means we're going to have to shut down again, which is going to cost the economy as well.
So you're not in favour of intra-Australia border relaxation?
If I was in Queensland, I would be keeping the borders closed, even though it affects me. I was going to go up there for a meeting next week, and they said, no, you can't come because you bring this nasty virus with you.
So the Prime Minister talks about snapping back. You're reserved about that approach?
Well, what does snapback mean? Does snapback mean we're just going to go back to what things were like before the virus came along? Or are we going to learn some of the lessons for the health system from what went on? So, the health system changed dramatically in a number of ways for the better during the pandemic. The telehealth experience just being one example. But, are we going to snap back to the old ways? Are we going to snap back to the new ways? What have we learned? And we've got to get something out of this experience we've all lived through for the last couple of months.
Now, you developed a model simulating the risks of various relaxation strategies to inform the future. What did you find?
So we developed this simulation model of 25 million Australians who went to school, go to the shops, go to work, and so we're able to simulate what actually might happen if you lifted restrictions, if you let big workplaces go back versus small workplaces, if you let the schools go back versus not. And obviously what's happened, if you run a simulation model a large number of times, you get a range of possibilities. And what we found was in some cases that you get quite a huge range of possibilities, and so that mirrors sort of good luck or bad luck, and you can have good luck or bad luck. And so you've got to think about do you emphasise the best possible outcomes, or do you emphasise the worst possible outcomes, or do you just stick with the middle? And what we found with sticking with the middle is that opening big workplaces and letting everybody go back to work is quite risky. We found schools are not so risky. And I think it's a combination with schools that, the kids don't travel as far. You can actually manage some of the interactions. But with workplaces, especially large workplaces, people travel more, and there's big chances of interactions within the workplace. And so, we could test the different options and the different risks.
And you talked about poor social distancing in shops being a problem, and it's interesting that one cluster in Victoria at the moment is through an H&M store, and interestingly from your other risk, which is large crowd events from the Black Lives Matter protest.
Yeah, so the H&M one was staff, two staff I think it was, being infected, and then obviously exposing the people who came and shopped there. And so you've got these, even though we've marked on the floors, where 1.5 metres are and all those sorts of things, it's obviously not been enough, and there's still these risks of people crowding at the counter, for example, or whatever. So the message we're trying to get across is we're not out of the woods yet. We've still got to be vigilant, and we've still got to try and make sure the public doesn't become too complacent.
Yeah, I think surveys, again, my Some 30 story tonight, the surveys showing that compliance with social distancing has dropped from 80% to 25% since April, so which backs up what you're saying.
Yeah, I think that, they saw that the risks of getting coronavirus were low. Even in Victoria, the numbers were down into single digits. And you say, I'm going to be quite safe. And it turns out they relaxed their control. People didn't sit far apart. We had these family parties, and I bet they were indoors, not in a mansion, and so they were quite crowded. And so we got the transmissions.
And just finally and briefly, the impact on the healthcare system. So we've had telehealth consultations, so mostly phone conversations. I hear on the tom-toms from the Commonwealth is that despite what they're saying that it's going to continue, they're unhappy because it's big expenditure, and you've got these standalone telehealth companies that are not necessarily providing comprehensive care to patients, and that there are going to be restrictions moving forward. What are the what do you think is the changing shape of our healthcare system from this report?
So, I've shared that concern about the standalone telehealth companies. I think we've got to. I think the Commonwealth has been sitting on telehealth for decades, and what they did with the pandemic was just introduce a mirror for the existing items, and so they just moved very quickly without the thought that one would have thought they'd put into it. So what we're saying is we want to ensure that telehealth in the future is all about continuity of care. It's all about strengthening the relationship with a GP, for example, and the patient. And so you might say, well, if you're going to have telehealth in the future, it's got to be in the context of an established relationship with a practice. And so don't just keep on going with the existing items, but think about what's going to be good for healthcare in this country, not just doing something quickly.
I'll watch and see what they announce. Stephen, thanks for joining us.
Thanks, Norman.
Professor Stephen Duckett runs the health programme at the Grattan Institute, and we'll have a link to that report on our website. This is RN's Health Report, and I'm Norman Swan. Almost 1 in 4 Australian women will suffer from migraine during their lifetime. For some, it's much more than a headache. Attacks can stretch over several days and start with visual disturbances and other unusual symptoms known as auras. If you've never experienced it before, this is how migraine with aura affects Donna Brooks.
People have different experiences, but mine is a very intense pain. My name's Donna Brooks, and I've been suffering from migraines, I actually think, most of my life. As a child and as a teenager, I would think I was just getting a really bad sinus headache. But as I got into my 20s, they became 3-day events. Initially, when I first start to get an aura, I feel as if something's not quite right, which sounds an incredibly vague statement, but it's a sense of something not being well, but not very easy to be specific about. From that point, I start to get flashing lights. The lights when I'm getting a migraine are very small specks. At first you almost feel like you're imagining it, but they are quite distinctly of a pattern, a very purple light, and it gets stronger as the migraine gets closer. I have food cravings and quite often mood changes. My mood either becomes extremely happy and euphoric or quite aggravated, and a very distinct sensitivity to sound. I've often said it feels like someone could have stabbed me because it is that painful when a normal noise occurs. That's usually the first half of the first day. And then when the migraine actually hits, it starts to become a sense of intense pain. I get a lot of pain, and it's always on the left side of my head. My migraines have had a huge impact over the last 62 years. Barbecues with friends, weddings, actually quite often ended up with a migraine. You start to fear the next attack. You wonder, did I bring it on by thinking about it?
And Donna was speaking there to the Health Report's producer, David Murray. A new study has found that women like Donna who suffer from migraine with aura also have an increased risk of heart disease. And it puts it up there with obesity and high cholesterol. Professor Tobias Kurth led the research. He's director of the Institute of Public Health at Charité University of Medicine in Berlin. And I spoke to Tobias earlier.
Thank you. Thanks for having me.
Do men get migraine with aura?
Yes, men get also migraine with aura, about 3 to 4 times less common in men than in women.
Now, we've heard one story of a woman with migraine with aura. Just give me a spectrum of what it looks like. First of all, migraine and then migraine with aura, because it's much misunderstood and also misdiagnosed.
Headache is a leading feature, certainly, but it's a pulsating, very painful headache. It's a moderate to severe intensity. And it really lowers down your activities. And the aura feature is most often a feature of the visual system. You see some sort of like zigzag lines or heat waves in your visual field, and that starts moving and stops after about 20, 30 minutes traditionally, and then the headache kicks in. Sometimes aura could also be like sensory symptoms, or you can't even move part of your body, which then of course is very alarming, but most often visual symptoms are part of the aura.
And can aura be the only manifestation you get of migraine? You hear of people with tingling down your arms and stroke-like symptoms, and they get nothing else. They don't complain of a headache.
That's true. And interestingly, that is quite common in the elderly. So if you have a migraine all your life, then the pain feature eventually disappears, but the aura feature remains. And then you only have the aura feature, but not a headache, which of course then is very difficult to distinguish that from a stroke. But patients with migraine with aura usually know their aura symptoms very well. A stroke is something that suddenly occurs. You have a clear symptom and very sudden onset. And the migraine aura is a progressive onset, so it's not suddenly. It starts slowly and then it moves in your visual fields, and that's the aura, and patients know this very well.
Now, I was kind of surprised to read your paper because I thought it was a done deal that migraine with aura increased your risk of heart attack and stroke.
Well, thanks for saying that, because we're trying to research on that since more than 10 years. And the link with
You mean I've just undermined a decade of research in one castaway phrase, have I?
Yeah, so the link between migraine with aura and stroke, I would say, is known because more than 50 years ago, the first studies came out. The link with heart attack has not been so much known, but the question was always, okay, so what? Migraine with aura may be a risk marker, but how does it relate with other vascular risk factors? So here we looked at the absolute effect of migraine with aura when looking at the same time of the effect of the absolute effect of other vascular risk factors. So we really could run models where we control for all the other risk factors and also estimate the absolute effect. And we see that migraine with aura is actually quite important as a risk marker.
So you used a group of female health professionals, a study based at Harvard, which has been going now for quite a long time, and started when these female health professionals were 45 or more. What did you find?
We found that migraine with aura is a quite important risk marker for cardiovascular disease. While having diabetes or currently smoking or having elevated systolic blood pressure are still the biggest vascular risk factors on the absolute scale, migraine with aura follows, and it's more important than being obese or having high cholesterol, which is quite substantial. So the argument that migraine with aura is not a strong risk marker if you consider other vascular risk factors is actually not true.
And if you've got both together?
That's what I wanted to just say. If you have any of the vascular risk factors and add migraine with aura, the risk was always higher. Or if you have a combination of vascular risk factors such as smoking, hypertension, diabetes, and so on, and you add migraine with aura, that's also then higher, sometimes substantially higher.
So some quick questions then. First of all, what about migraine without aura?
In the women's health study, which is the underlying study cohort, migraine without aura was not linkable to an increased risk of cardiovascular disease events.
Does treatment for migraine reduce the risk? And does treatment for cardiovascular disease, such as, say, prophylactic aspirin, change the risk?
That's actually the big question, and we do not have good data on if I treat my migraine, will I reduce my risk? We recently did another study where we looked at preventative medication for migraine and cardiovascular disease outcomes, and we couldn't find a clear picture. The issue is really that some of the preventative medications are also given for other reasons, such as high blood pressure, for example, so beta blockers. And so obviously we cannot be sure that the medication has been given solely for the migraine. So very difficult to really study this. In terms of cardiovascular medication that reduce cardiovascular risk, it's also not really clear whether in addition to the effect that you definitely have if you treat hypertension, migraine with aura would then have an additional benefit. Overall, there is no indication, but certainly what we know is that if you have hypertension, if you are currently smoking, that if you treat these risk factors, it will reduce your risk of cardiovascular disease, and that's independent if you have a migraine with aura or not.
And this emphasises that migraine is a disease of blood vessels.
Definitely a disease of blood vessels of the brain, but it's also a disease of blood vessels throughout the body. And we have some evidence that the physiology of the blood vessel changes if you have a migraine with aura, but we still do not understand why it is that migraine with aura increases the risk of cardiovascular disease. That's why I call it a risk marker and not a risk factor.
So what's the discussion that a woman who's having migraine with aura, or indeed a man, should have with their general practitioner?
It is important to understand that if you have a migraine with aura, you can use this as a risk marker. So you know that that person is at higher risk of getting cardiovascular disease events, which means that you should look maybe more closely on other vascular risk factors and the entire picture. Do I have a vascular patient in front of me, and do I need to do something? We do not know that treating migraine in terms of preventing migraine will reduce your risk, but if you have a migraine with aura and you have had a cardiovascular disease event, then some of the medications are contraindicated. So you need to understand what can you do, what can you give to make the migraine better.
Tobias, thank you very much for joining us.
Thanks very much for having me.
Tobias Kurth is Director of the Institute for Public Health at Charité University of Medicine, Berlin. The paper is published in the current issue of the Journal of the American Medical Association. Do you think of yourself as a non-smoker but still like up in the pub or over the weekend? The message from anti-smoking campaigns in Australia has long been that every cigarette is doing you damage. Still, the perception persists that a cigarette every now and again carries little or no risk compared to smoking every day. Research from the United States may overturn that by revealing exactly how much non-daily smoking increases your risk of death. Dr. Maki Inui Choi is an epidemiologist at the US National Cancer Institute in Bethesda, Maryland, and I spoke to her this morning.
Of course.
It's surprising that we don't know very much about this group of people who have moved from regular smoking to intermittent smoking.
Yes, that is really unfortunate that we don't know much about this smoking pattern, because non-daily smoking pattern was not common until recently, so the study hasn't been done much yet.
And what's the pattern that we're talking about?
Non-daily smoking is usually the smokers who smoke on some days but not other days. So some groups of people smoke only on weekends, but other people smoke maybe just one cigarette a day, but maybe like 5 or 6 days a week.
And how did you study it?
In this study, we looked at the data from a national sample of over 500,000 U.S. adults, and these people reported their smoking behaviors. We used the surveys from 1992 to 2011. And using reported smoking data, we assessed the risk of death among smokers compared with never smokers. We looked at death overall, and also we stratified by cause of death. So we looked at the risk for death by like cardiovascular disease and lung cancer as well.
And what did you find?
First of all, we found that like non-daily smokers, so these people smoked non-dailies in their lifetime, so they never smoked daily. These people had nearly twice the mortality risk than never smokers. And we saw this elevated risk of death with even 6 to 10 cigarettes per month, a lot lower than 1 cigarette per day. And we also found that smokers who reduced their smoking levels from daily to non-daily had lower mortality risk than daily smokers. And the risks were lower with longer time since reducing. But smokers who quit overall, so altogether, had even lower risk of death.
So just to summarise then, if you've only ever been a weekend smoker or smoked maybe a cigarette a day, 5 or 6 days a week, then you've got double the risk of dying compared to never smokers. If you cut down from, say, 10 or 20 cigarettes a day down to one a day or just a couple at the weekend, you've still got a higher risk of dying, but it's less than if you smoke a lot of cigarettes every day.
That's correct.
And one of the things that I've often talked about, and I just wanted to know whether you got it here, is I've often seen graphs saying the first 10 cigarettes are the most dangerous and then it evens off. So in other words, it's not a straight line, that even 1 or 2 cigarettes can be quite dangerous. Did you find a straight line here between total consumption, or was it a very steep rise and then it tailed off?
That's a good question, because there are lots of studies that showed the first cigarette has the most effect. We did kind of see the similar associations, but the challenge for us is there are not many people at the low level. So it's hard to say there was a biggest effect in the first category of the lowest level.
And the causes of death were not surprising? In other words, it was from smoking-related diseases, heart disease, lung cancer, stroke?
Yeah, we saw the strongest association for lung cancer and respiratory disease. But we did see a weaker but important association for other diseases such as cardiovascular disease and stroke and others.
So the bottom line here is that there's no safe level of smoking.
Yes, we do find, reducing from daily to non-daily smoking does reduce your risk of death, but quitting has most benefit. So our main message is there is no safe level of smoking, and all smokers of any level should quit.
Maggie, thank you very much for joining us.
Thank you.
Dr. Maki Inoue Choi is an epidemiologist at the US National Cancer Institute in Bethesda, Maryland. There are 6 stillbirths a day in Australia. That's 6 families devastated by losing a baby unexpectedly. Yet it's possible that 2 of these 6 stillbirths could be prevented by 5 measures wrapped into what's called the Safer Baby Bundle. The aim is to reduce stillbirths in Australia by 20% by 2023. But one of the people behind the initiative has today sounded a warning in the Medical Journal of Australia, saying there is potential for harm unless care is taken. Ewan Wallace is Professor of Obstetrics and Gynecology at Monash University and Chief Executive of Safer Care Victoria, whose aim is to improve safety and quality in Victorian healthcare. Welcome back to the Health Report, Ewan.
Thanks, Norman. How are you?
Not bad. What's the definition of stillbirth in Australia?
In Australia, it's the birth of a baby without signs of life beyond 20 weeks of pregnancy or over 500 grams birth weight.
I thought it was much later than that, like after 28 weeks.
No, and one of the challenges when comparing countries across the world is that definitions vary across the world. So in Western Europe, most countries use 24 weeks, but the WHO uses 28 weeks.
What are the 5 measures in the Safer Baby Bundle?
So nothing very unsurprising, really. So the first is to encourage, support women to stop smoking, because we know smoking greatly increases the risk of stillbirth. The second is about improving awareness of sleeping position of the mother, particularly in late pregnancy. She should sleep on her side, not on her back.
That's because of pressure on the blood vessels going to the placenta, is it?
It is, yeah. And particularly in pregnancies where the baby's growth restricted, where there's already compromised blood flow through the uterus to the baby. Then the third is about decision-making around timing of birth, actually the most complex of the 5 measures, which is tied into the last 2 measures, which are improving the detection and the care of pregnancies where the baby is not growing properly, so-called fetal growth restriction. And lastly, improving the awareness and the care of women who have decreased fetal movement, so whose baby's movements change, again, particularly in the closing weeks of pregnancy.
Which can terrify women when they feel the baby not moving as much.
Yeah, and I think one of the challenges around providing those women the best care is that some women understandably don't come forward because they're so terrified. Just in the same way that people don't come forward with signs of cancer sometimes because they're terrified.
Now, you're worried about particularly the last two, which relates also to the timing of birth, that by pulling the trigger too early, an unfortunate metaphor on my part, on fetal growth retardation and to reduce fetal movements, that you might actually have an increase in premature delivery.
Yeah, because the stillbirth can be prevented by simply delivering the baby. And so the earlier you deliver babies, the more effective you can reduce the rates of stillbirth. But that's not the whole picture, of course. And you can increase neonatal deaths. And as we've learned over the last 5 or 10 years, if you deliver babies too early, you impair, even at term, so even at 37, 38 weeks, you can impair their long-term educational learning outcomes.
Yeah, we had Jonathan Morris from North Shore Hospital in Sydney talking about that recently.
Yeah.
And so what's the answer here? Because you're an obstetrician, the baby's not growing well, or there may be decreased fetal movements. How do you know when to say, well, I think we need to deliver the baby now?
Well, I mean, ideally what we need are markers to tell us the baby who's in trouble, and we don't really have those markers yet, although there are groups working on that, both here in Australia. There's a group at the Mercy Hospital here in Melbourne that's working on it, and a group in Cambridge in the UK that's trying to develop essentially simple blood tests that could tell us this baby's in trouble, irrespective of its movements, irrespective of its size. Until then, what we have argued for in Victoria and what we'll introduce in Victoria this year for the first time is what we call balance measures, really measures of possible harm. So unintended deliveries, babies that were delivered because the care providers thought they were small, but actually their birth weights were normal.
So what are you saying? You have those measures in place, then you can give feedback to the obstetricians?
Exactly, because I think, we published a paper late last year showing that, not rocket science, if you tell clinicians, if you tell hospitals how well they're doing, and we think particularly if you make those data public, publish them for everyone to see, that actually we harness the intrinsic desire for clinicians, midwives, doctors to do the best they possibly can. Well, we think the same is true for balance measures. If you tell them that they're, if you show them that they're perhaps delivering too many babies too early in comparison to others, that they'll learn ways of decreasing that.
We've only got a few seconds left. What are the questions then that a pregnant woman should be asking her midwife or obstetrician in relation to this?
Well, I think probably questions that are relevant for all healthcare. What are my choices here? What happens if I don't do this or if I do the other? So exactly the same questions that are present in all of healthcare. I mean, I think that the key thing for women who are particularly in late pregnancy, if they have any changes in their baby's movements, they should phone their hospital, phone their care provider and present. And again, very simply, they should be going to sleep on their side rather than on their back.
Give up the fags. Ewan, thanks for joining us.
Thank you.
Ewan Wallace is Professor of Obstetrics and Gynaecology at Monash University in Melbourne. He's also CEO of Safer Care Victoria. That's the Health Report for this week. I hope you'll join me next time.
You've been listening to an ABC podcast.